Hello, everybody. I remember 2001. It was my first time to participate at the EAED. It was in Venice. The meeting was organized by Mauro Fradiani. And for the treatment planning session, Nitsan, he was presenting at that time. I was really amazed by the quality of the presentations, and that's why I've kept following this academy, and I'm proud to be an active member of it. So it's a great pleasure and honor being here today and given this opportunity. And what I'm going to share with you today are two cases. For those who know my presentations, I'm not going to speak anything about digital today, or digital technologies, or digital dentistry. We're going to go back to the roots, and we're going to discuss the basics. What is the best treatment plan for the cases that I'm going to show to you? And from my perspective, as I told Stefan and Giulio, that the second case would be more interesting than the first one in terms of the discussion. So without any delay, we'll start with the first case. And during the course of the case, you will be seeing QR codes, either to participate in the presentation and provide your feedback, or to download the related literature to the papers, or the papers related to the cases that we are presenting. So the discussion was also with Paolo and Giulio is what are the guidelines for the presentation he showed at the beginning. And the steps that I'm showing to you here, they supposed to be followed by all other presenters in the future that are going to present in the treatment planning session. So the first case was treated in our department a number of years ago, 74-year-old patient. He was an engineer, he's retired now, non-smoker, healthy. His chief complaint was the increased or marked mobility of his teeth and impaired ability to masticate. And his wish was a new, preferably fixed prosthetic rehabilitation, improved of masticatory function, to gain a beautiful smile. Now, we go through comprehensive charting that we developed with the help of a couple of postgraduate students at the University of Freiburg. And we start, of course, with an extraoral analysis. We check for the proportions, we check for the profile, and you can see here that we have relatively symmetrical proportions. As for the intraoral examinations, we check, of course, we can see here immediately that we have some insufficient restorations in both jaws, in the upper and lower. We have recessions happening, so we can assume that there is an involved periodontal disease. We have, of course, in the mandible here, pus was coming out of the mandible, and of course, the oral hygiene seems not to be appropriate. As for the radiographic examination, we can immediately identify that the patient had a number of insufficient restorations. We have clearly periodontal involvement. We have some periapical lesions. We have some root canal treated teeth with periapical involvement. We have also two implants that were placed previously, and they have an implant, two supported fixed dental procedures delivered in the lower left. As for the further examination, we go for the dental now. Sorry for that. Go back. You can immediately see that for the periapical x-rays, we can now clearly identify how much more resorption has happened, especially in the lower anterior region, also on the upper left, as well as on the upper right. The analysis again depicted that all existing restorations in the upper and lower are insufficient. Further analysis, which of course is the periodontal charting, we go through comprehensive periodontal charting for all cases. Here you can see now everything what is marked in red has a pocket depth equal to or larger than 5 millimeters. Of course, bleeding or probing was existing everywhere, so we have an active situation, and we have marked attachment loss nearly on all teeth. Now, not to forget that we have furcation involvement in nearly all molars, and that was between grade 2 and 3. Furcation involvement plus the insufficient oral hygiene. but amazingly, the implants that the patient already had in the lower left were fine. Of course, we have to think about the function. How is the situation now from a functional perspective? We have a neutral occlusion type, an overbite of 3 millimeters, overjet 5 millimeters, and an interocclusal rest space of 3 millimeters. And we can also, this is something to be discussed, as Alessandro suggested, is to mount the models in terms of digital articulators and simulate the movements if possible, but I find it very attractive to have them mounted digitally in order to identify the contact points. I'm not sure about simulation of the function because this is something that we have to discuss, but it's very nice to check for the static occlusion. So we can then transfer this into our charting, and you can see we have multiple contacts in the maxillointercuspal position. The contact extruding protrusion went through exclusively through the anterior teeth. One premolar was involved. The relaxed guided movement was possible. The CO coincided with the MIP. No abnormalities in the temporomandibular joint, and the lateral movements to the right and the left went exclusively through the premolars and the canine. Now, of course, we have further analysis for such cases. We have to go for the aesthetic analysis, and I think Mauro has a very nice app that can aid all clinicians in order to perform a proper aesthetic analysis. We went all those these things, and of course, you will be able to see them at a later time point, but the main thing is that we have irregular tooth axis. The form was irregular. We have interincisal angles that also were irregular, as well as the gingival zenith. We have missing papillas in both jaws, and of course, we have crowded teeth, irregular incisal edge position in the lower jaw. And of course, after collecting all this information, we have to set a diagnosis, and these are only bullet points that denote what is the major finding that we have observed. And this would be extraoral, minor facial asymmetry. Intraoral, we have a fistula in the lower right lateral incisor, multiple insufficient restorations, and secondary and cervical caries. Periodontal, we can go to the classification of Armitage, and we can denote it as a chronic generalized periodontitis in severe form. We have apical periodontitis in upper right first premolar and multiple insufficient fillings. Root canal treatment, of course. We have insufficiently restored adult partial dentition. And for the aesthetics, of course, we can all agree that we have compromised aesthetics. So the tooth prognosis that I have set, and we have 4 parameters to set the tooth prognosis. And those are, of course, how much remaining tooth structure is there, so the hard tissue. The second one is the amount of the periodontal support. The third one is tooth vitality. And of course, we have to discuss with Oliver if a root canal treated tooth and needs a retreatment, what is the outcome of this? Of course, this would be different than, maybe he would disagree, than a tooth that is already vital and has no root canal treatment. The fourth parameter from a prosthetic perspective is the strategic location of the tooth. So we take all those 4 parameters and then we set the prognosis of each single tooth from a prosthetic aspect. So we can see here that I have set number together with the colleague that was also seeing the case, the number of the teeth that were deemed as hopeless and needed to be extracted. We have some teeth that deemed to be questionable, and these will be later re-evaluated after we perform the first step of the treatment or segment of treatment, motivation to improve the oral hygiene, do the debridement, and then go ahead for the re-evaluation and see the outcome or the prognosis of the tooth. On some teeth, including the 2 left implants in the lower left, they were deemed as having good prognosis. So I would like to invite the expert of panel experts to step forward, and then we can start the discussion.
Come on stage. And please remember to your friends that they not only can follow on streaming, but they can also vote. Okay, from home they can vote to the decisions. It's important to remember that. And okay, please sit. So the first, according to Stefan, we would like to start from the endo issue. So the first, are you ready? The first question goes to Olivier. And please, what's your problem, your prognosis? I mean, the prognosis from your standpoint in this case.
Okay, perhaps we can highlight endodontically involved teeth from the periapical X-rays. Is this possible? In order to explain to the audience.
Unfortunately not, no.
Okay, so let's start with the upper right first bicuspid. It has been endodontically treated and it shows a periapical radiolucency, meaning it's a disease. It's a question, what I can say endodontically, if we look at the literature, the evidence says that we should have a prognosis of about 80% if everything is professionally performed. So let's put it like that. I would do the retreatment first, and then in case that the lesion doesn't heal, we always have the chance to do a microsurgical procedure. So putting everything together, I would say the endodontic prognosis for the tooth number 14 is a good and reasonable prognosis to integrate this tooth as an abutment in the final prosthesis. So I would have to look again. I think the upper right lateral incisor is also in the endodontically treated. I don't remember if there's a periapical lesion, but it's not a proper endodontic treatment. So from the endodontic standpoint, I would say the prognosis for retreatment is good, but on the other hand, I would be scared about the periodontal situation. So finally, I would...
Sorry, I interrupted. I want just to remind to all the audience that also the experts, they haven't seen the case, like you, okay? They're exactly like in your situation. Me and Stefan, of course, we have seen the cases, but you don't, so it's good. It's a good challenge. It's a good challenge.
Giving the recommendation according to this tooth, I wouldn't trust this tooth due to the periodontal involvement, meaning the major bone loss and the root structure. So this is not a very strong abutment I would trust on. Upper left central incisor, to me it looked like a tooth which has been previously surgically treated. It has lost a lot of tooth structure, so meaning according to the tooth structure, which is highly reduced, which is left, I would recommend to get rid of this tooth. Then upper left first molar. Again, here I see the main issue not in the endodontic situation, but in the periodontal involvement. So I think this tooth wouldn't be worth to think about endodontic retreatment. Then we have another problem, lower right lateral incisor, is this correct? Which has been or where you said there's a fistula, so I would like to ask you first, what is the reason for the fistula? Is this a periodontal reason or is it an endodontic reason? So if we are sure it's an endodontic reason, we can fix it again and by an endodontic treatment by a very good, or let's say by a good prognosis.
Okay. If I might ask you, Oliver, thank you for your feedback. Now, you are the best expert in this aspect. Do you still recommend two-dimensional images to evaluate already root canal treated teeth and then assess the situation for a retreatment? Or how is your approach nowadays? What would you recommend? Because some of the colleagues I hear that they go for cone beam CT nowadays rather than going for the periapical regions in order to better assess. Is it true? And what do you think about it?
So I would say as a first starting point, I would use definitely periapical X-rays in order of radiation reduction. If there's a retreatment case and there may be perhaps a perforation or missed canals or different other issues, or a tooth which already has been surgerized before, I would highly recommend to do a cone beam small field of view technology also, additionally to the periapical and eccentric periapical x-rays, in order to do a proper diagnosis. Because I can see, let's say, we are talking about the first bicuspid upper right one, and I don't recognize in advance that this tooth has already been surgerized before, and let's assume the complete buccal plate has gone. So if I retreat this tooth and I say, okay, let's keep it for your reconstruction, I give you a bad recommendation. So this would be an explanation why I would highly recommend in these cases for retreatment issues, I would highly recommend to get an additional small field of view cone beam.
Single-rooted, multi-rooted teeth.
Doesn't matter.
Doesn't matter for you?
No, let's
for,
say...
I mean, for retreatment.
No, doesn't matter, because let's say we have a single-rooted front tooth with a post inside of it, and I can't really recognize that's a perforation to the palatal or to the buccal side, which has an impact on the prognosis of the tooth. So if I miss this information and I give the recommendation, so let's go ahead, and we schedule the patient, and then in the middle of the treatment we see, okay, we get in trouble, and we have to change the treatment plan, the patient won't be so satisfied. Okay, also it doesn't matter if that's a single or multi-rooted tooth.
In terms of the outcome, it doesn't matter for you. I mean,
No, we are talking about
treatment.
we are talking about the treatment planning first now.
No, but I mean the prognosis of treatment. According to your experience, or what does the literature say about multi-rooted versus single-rooted teeth in terms of retreatment?
No, it doesn't matter.
Doesn't matter.
No.
Okay.
All right, thank you very much for this endodontic prognosis. I would like to go ahead with the perio prognosis and invite Arndt Hoppe to tell us his opinion about what to do, about what could be the potential prognosis for these teeth. I mean, we of course understand that the patient has to go through an initial hygiene treatment and then would be re-evaluated. I think in this group we understand that of course this has to be done, but in terms of shortness of time, we cannot discuss everything in detail, otherwise it would be too lengthy.
So, can you hear me? Is the microphone on? Yes. So at this time point, I would fully agree with the Weil's assessment. And of course, we have to wait for re-evaluation, as you told. But so at this time point, I completely fully agree to your prognosis you just showed. We have like 4 teeth that have a fair prognosis in the upper jaw, and in some 5 in the lower. So I think it's always difficult to talk about this at this time point, because you need to go to a quite long hygiene phase before you can really evaluate the case.
Okay. If I might just ask Arndt, thank you for your feedback. Long hygiene phase, what is your approach? What is the approach that we should usually follow?
Usually we follow a debridement phase. We do a non-surgical approach and then re-evaluate the case after 3 to 4 months.
Regardless of the pocket depth, for example, over 5, like, is there an approach like you say if you have more than 6, 7? I think also Julio can comment on this. Do you go immediately for a surgical one? Some colleagues, they go for it, or they just go for the conventional approach or non-surgical approach, and afterwards, after the reassessment, they go for the surgical one. What is
Sometimes we extract hopeless teeth in the early phase, but we always go for a non-surgical approach in the first place.
Okay.
Yeah, let us meet another question. What about the use of antibiotics? And then I will give my opinion. What's the use of antibiotics in the control such as infection?
Well, I'm not a periodontalist, but usually we go for bacterial assessment and then decide if we go for antibiosis. Yes, for the Van Winkler cocktail.
Okay. Because
I think Hannes is here. He can also comment about antibiotics. Maybe you can say that something, Julio.
You mean from the?
Yeah. Also, we can. I don't know if you would like to involve the audience now.
It's like we are ready to open.
Yeah.
Yeah. What I think it's this phase. We say, okay, this preliminary phase we give like done. Okay, But this is a chronic periodontitis, but it's a severe form.
Yeah.
So when we have this severe form, according to the literature, we know that when you have a deep pockets, that's benefit from adding the antibiotics therapy, this severe form, because the aim is to eradicate the periodontal pathogens. So you can do with motivation first, instruction for hygiene second, and third, control the infection. And to eradicate these periodontal pathogens, you need to do a very strong non-surgical phase. And in a case like this, I will recommend also with antibiotics. And after a period of reevaluation, that can be after 2 months, and then after 2 months, you need to make the periodontal charting again. Many people does the periodontal charting only the first time, and then they forget, they don't do anymore. Then after 2 months, you need to compare the new situation with the previous one, and then after other 2 months, you need to compare with the second one. Until you have an improvement in the pocket depth, you maintain the teeth, and you keep going. When you stabilize your improvement and you have a pocket, according to what we know from Matuliene and others, you will need to do surgery to reduce the pockets. Okay, this is the concept in
something?
Of course.
It's a microphone.
Koray, please.
We could talk a day and a half on this, couldn't we? The first thing I would ask, I'm sorry if I missed it, but you said his medical history was clear?
Yes.
No medical history.
Yes.
One of the things I would do in somebody this age who is presenting with this level of disease is to ask how long it's been going on for, because if it's something that is suddenly exacerbated, I would actually like to do a diabetes test on him first to see whether there's a systemic reason for the advancing infection. And for sure, I think I agree with Aunt, and Julia, we need a very aggressive antibiotic-based.
So you might assume that somebody for his age might have a diabetes.
It may be, because if he's been stable for a long, he's kept his teeth until 74.
Yeah, we can exclude this because he's going on a regular basis for a checkup.
Fine, all right.
Basis,
So in that case, then it is aggressive. But I have to disagree a little bit about you saying that teeth have a hopeless prognosis right from the outset until we see what the response to treatment is. I think we need to make that decision after the infection has been controlled, and also the vitality tests on the teeth and see if any of those are perioendo, whether the periodontal treatment will be benefited by elective endodontics as well.
Yeah.
On any of those posterior teeth.
Sorry, we are running a little late, so thank you very much for your contributions. Is there any more questions in the audience? If so, please, the microphone.
Nitsan. Yeah, he has a question, I think, right?
Once we are done with the discussion, the idea is to come up with a voting again, so that you have 5 votes, possible votes for possible treatments, and then you're going to see what Weil is going to show us.
I just wanted to add that when going through a case, the first stabilization period, when you try to control the perio and bacterial status, improving the hygiene with or without antibiotic, in such a case, when you know that all the existing restorations anyway will be removed, either with the tooth or without the tooth, I would add to it trying to equilibrate the occlusion at this stage with the present restorations, and I would definitely add the night guard to such a patient.
Yeah.
That's the only thing at this stage.
Thank you, Nitsan. Is there any other questions from the audience? Or comment?
Okay, we move. Okay, one.
Then we go ahead.
There's one.
There's one.
The financial status.
No limits.
Thank you.
Fantastic.
Yes, Aunt, please.
Add something. Yeah, what you said that his chief complaint was tooth mobility also.
Yes.
So does this refer to all the teeth or just some, like 1 or 2? Because usually you have to address the chief complaint in the early phase, otherwise you lose the patient. So you should maybe stabilize the 1 or 2 teeth that he addresses. And also, find it always difficult at this time point to do proper treatment planning, because you have to get to know to the patient and interact and see what he really, what's his, yeah.
If I can, okay, as I know from my mentor Giano, tooth mobility is due to two factors: inflammation, and we have a lot, trauma from occlusion, and we probably have. So just fix those two, starting from the control of inflammation. That's it, right? It's not a big issue usually, tooth mobility.
Hannes,
Hannes.
you're getting one. Behind you, Hannes.
Just two comments. What kind of antibiotics aren't what you use, and is bacterial or microbiological assessment really will change your decision in selecting the proper antibiotic? This is first question. And then second, it's just a comment. If you look at the first upper molar, just go back at the probing depths. The periodontal, if you go back to the probing depths, the periodontal involvement is just on the distal root of that molar. So, and because, you know, the other teeth will have crowns, so you could stabilize that tooth, you know, like Carnival and all the others have shown. So there might be a way to keep that tooth, because you just, you know, gave him hopeless. You can extract. It's not, you know, mistake, but you also could consider to keep that molar.
Okay, thank you, Hannes. The type of antibiotics, according to the literature, there is a large evidence today about that, is from Magda Ferres, from Sgolastra, from David Herrera, and from Hafaji. We know that it's an association of amoxicillin and metronidazole. It's both for aggressive periodontitis, that's for sure, but also for chronic periodontitis in case is a severe. There is deep pockets. We know from David Herrera, 2003, that we have a benefit from the use of an association, amoxicillin metronidazole, for 8 days, together with the non-surgical therapy, not the antibiotic themselves, but simultaneously to removal of the biofilm, and there is evidence that.
I fully agree, but is it important to assess microbiology? And to find out what kind of microorganism you will find, because you use anyway the so-called Winklehoff cocktail.
Yeah, but removing the
You
teeth.
will eradicate.
Look,
everything.
with removing the teeth without removing the bacteria will stay
I
there.
agree.
It's not a therapy removing the teeth. Period.
No,
Okay, we need to move forward. Okay.
Regarding to your question, Hannes, about the periodontal involvement of the upper left, the upper right. Let me just go back to it.
12-millimeter pocket there.
Yeah, it has a huge attachment loss, and I will show you the photo afterwards of the root, the exposed root surface. That was the reason for it. But
Okay, move forward. Move forward.
go forward for the.
Yeah.
It's okay.
Yeah,
Maybe we have to.
Can I say something?
No, let me just. There's another question here.
Yeah.
Ah,
there's a question.
Giano.
One more question, just quickly. Sorry.
Okay. No,
Oh,
I'm
Jan.
just very concerned about treatment planning this case, looking at the initial charting.
Yeah.
It's almost impossible,
Yeah.
except for the teeth, which obviously are lost because of the extreme mobility. But as periodontists, we treat mobile teeth every day. So what we want to see is the response of the periodontium to the non-surgical phase of therapy. And then we finalize the plane, giving all the options to the patient.
The problem,
So
Giano, I agree with you, and we discussed about that. The issue they have in Germany, they say, I know this is an European, so global, but in Germany, they need to provide, correct?
Yes.
The prosthetic treatment plan at the beginning. So because the full arch was involved, anyway, they need to have roughly.
Okay, I want to ask a question to the audience. How many patients will jump on the chair if you touch them with a probe at the very first visit?
Yeah, most of them.
Because the inflammation will be, in such a case, is so high that the patient will move, will go away from the office. So basically, for instance, in my office, being in this business for 45 years, I don't make the charting at the first visit because it doesn't make sense. I do the charting after the non-surgical phase of therapy. Now, if there are situations for insurance or for, then it's another story. But nevertheless, I think that we have to bear in mind that these measures are really an indication. They don't mean that much. Also, the fact that if a patient probes 6 or 5 millimeters on overall treatment doesn't make that much difference. It's the shape of the defect, it's the way the patient reacts and so on.
Can I ask one more question?
We are running.
Yeah, you have
otherwise
a point, Giano.
We have another case, and
Yeah, this is the problem, is that there's always no time. You
Does
have
the
a
patient
point,
wanna
but
save his
again,
teeth?
This was enough.
we have in many cases to go for, our approach is to go for the full charting, full analysis, and it's also, we can debate about it here and discuss it if we would like to, not to go for periodontal charting, to control the infection first, have this infection go down, and then go for the periodontal charting. We can discuss it, of course, and
Okay, let's move to the votation.
information about it. Anyway, now it's your turn. Please, you have the QR code provided on the screen. You can scan it, and then you will come up with different questions. I mean, we didn't have the chance to ask the panel here about what they would do in the case from prosthetic point of view, but I'm going to show the different options, and then you will provide your feedback, what you would go for, and then also you will provide your feedback. So regardless of the number of the teeth that we are going to extract, regardless of the remaining teeth, we have different approaches. Either to go for a fixed rehabilitation by installing additional implants, forgetting about, or not forgetting about, we need to maybe go for bone augmentation procedures to enhance the implant site. The second modality is to go for a removable dental procedures, and that would be either to go for clasp, retained, involving the implants or not involving the implants. So we just defunctionalize these implants. The last one, modalities 4 and 5, would be there's something that we do in Germany, in Austria as well, and also in Japan, is the telescope-based procedures, where either to involve the implants with the teeth in the same procedures or not to involve them. So the question now for the audience, and also I think first for the experts, what option would you go for?
let's probably start with Corey. What would you choose?
I think it's
Would you recommend
I think it's impossible to say. I think at the moment, without seeing a response to
Can't hear
initial
you,
treatment,
Coran. Can you speak?
without having a response to initial treatment, it's impossible to say. We haven't had an orthodontic input. We haven't had. I have no idea what the starting point is for this procedure until we've actually settled the disease. If you're being very aggressive, then I guess then you remove the teeth that you feel are going to be poor prognosis and you go for the implant option. But I certainly wouldn't like to place a removable clasp retained denture in this patient. Maybe a telescopic would be preferable to that, but I'd certainly go for a fixed solution if I can.
So you won't
But
go
it's too
for
early to say.
2 or 3, you won't go for it. What is your preferred treatment option? Given that the prognosis,
Pardon me?
the prognosis of the existing teeth coincides with what I have said in that case. Would you go for implants or you go for a removable?
I would definitely go for implants.
For implants.
I would definitely go for implants. I would prefer to avoid a removable.
Arndt, what you say?
Depending on the need of the patient. It's always an individual choice you take.
He's requested fixed.
Yeah, you requested fixed, so, but people, they don't have an idea about, like, if you have a removable telescope, full arch reconstruction, this is like fixed and it's easy cleansable.
Yeah.
If you tell the patient, they,
Please,
Many-
just
in many
no, because
cases, I agree.
to stay into the timing, just say 1, 2, 3. That's it. and
Okay.
then you vote as well, and then we move forward.
Yeah.
Okay? There is a lot to do.
so I would go for, I would try to involve implants and go either for removable or fixed.
Okay.
So indecisive.
All right.
So what do you think about it? You have 30 seconds, please. You have the questions here on the up. And scan the QR code again and provide your feedback.
So please, the vote is now open for voting for the next 30 seconds. You want to do that now?
This is the wrong approach.
I agree. You may. You would find that with good treatment, good ortho, good maintenance, you could probably keep a lot of those teeth.
Of course.
Yeah, maybe 74.
Okay.
All right, thank you very much. The voting is closed. Can you give us the results, please?
Okay.
All right, that's a clear result.
Tooth implants, supported crowns, and fixed
So
dental
just for the panel that you know, 74% is for the solution number 1 with implants, additional implants. There's a 19% for tooth implant supported telescope retained solution, and the others are 3 and 1%.
Pretty much right.
Okay, interesting.
Okay.
Bio, please.
Okay. Then I will be happy to show you what we have done with the case. Of course, back to the treatment modalities that we have. We have the advantages. Aris? Yes, please. Microphone.
Here's the microphone.
Excuse me to interrupt. So we mean that we extract all the teeth and we don't have an option to save the teeth at all?
Now you're asking me. I told you from the beginning, Aris, is that we take the 4 parameters, which is the remaining amount of tooth structure,
Yeah.
periodontal support, vitality, and strategic location of the tooth.
Yeah,
We
but-
do an initial treatment plan. Which teeth are hopeless, which teeth are questionable, and which teeth need to be extracted. We do for the hygiene phase, we go for the re-evaluation after 8 to 10 weeks, and then we assess whether the remaining teeth can be further, the questionable ones, do they have a bad prognosis or good prognosis. And then either we stick with the plan that we have set or we go forward with a modification.
So we don't discuss the possibility of involving the teeth with good prognosis in the final treatment plan?
Of course we do.
We do?
Yeah, of course.
These designs?
What?
In these designs you showed us?
Yeah,
Now we show it now.
yeah, it's coming
I was
now.
going to discuss his rationale, which are the advantages and disadvantages of the various solutions.
Yeah. So back to the presentation now, we have different options. And these can be, again, either fixed, clasp retained removable, or telescope retained. And according to this here, we have advantages and disadvantages of every technique. Of course, we have to check for patient comfort. With fixed, of course, it's the best one, but with the telescope retained, according to the literature, I will provide you also with the literature, it provides a good comfort of the patient, the quality of life as well. Now, in compensation of ridge defects, we do know that if we have loss of the bone in the anterior region, we don't have lip support, you cannot compensate it easily with a fixed rehabilitation. So a telescope retained would be even better to do this rather than or a removable would be better than having a fixed rehabilitation. Aesthetics, best achieved, of course, given that you have enough bone and soft tissue with the fixed rehabilitation. The invasiveness, given that we might need some bone augmentation procedures and something like this, then it wouldn't be that easy to go for fixed. But of course, the same thing with the telescope retained, you have to prepare the teeth a lot compared to the clasp retained. So the most conservative one would be the clasp retained approach. The fabrication complexity with the telescope retained is more technique sensitive than the other two. As for the extensibility and repeatability, if something happens with the fixed rehabilitation, then of course we might need to install an implant and redo the rehabilitation. But with the telescope retained, you can modify the procedures without any additional measures. So it's very easy. If the patient, he's 74, don't forget, if he loses a tooth, then we don't need to do that much. just fill up the gap and that's it. Now, for palatal coverage, we have learned from the literature that palatal coverage is not needed whenever you have 4 or more well-distributed abutment teeth in the upper. Same applies for the implant-supported rehabilitation, but for the clasp retained, we have to go for it. The performance of oral hygiene with a fixed rehabilitation is not that easy compared to a telescope retained prosthesis or even to a clasp retained one. What?
Tito disagree.
Well, if you have a limited manual ability to do, the patient will not be able to use the interdental floss or the interdental brushes and put them underneath this fixed rehabilitation that you are using.
Does he have a limited manual ability?
Not yet, but he's 74.
Well, no, come on.
Not
You
yet.
don't extract the teeth because your patient might in the future not be able to clean them. I
No,
mean,
if you look at all the research from Frauke Müller and what they are doing, even from Canada, if you have a rehabilitation that is removable with non-splinted abutments, it's easier to clean. It's logical. It's easier to clean than
but
splinted ones.
this is just a treatment bias according to which region of dentistry you're in and also the type of dentistry you do mostly in your practice. Because if you do a lot of telescopic, you favor it. If you do a lot of fixed, you favor it. So I don't think this is a fair assessment, because if you are doing the evaluation and you prefer to do a telescopic, then you're going to favor that in the research and vice versa. So I think this is not something we can say, when you say in the fixed list that oral hygiene performance is minus, I totally disagree. In my practice, I would say it's much better in fixed than it is in removable prosthesis.
Do you do telescopes?
I don't do telescopes, no.
You don't know them.
But that's
You
the
don't know them.
point.
It doesn't
But-
exist in the United Kingdom.
Okay, but then
Yeah, it
That's
does.
fine.
It does.
But
it
I
does
don't
exist, and
see
there
the
are cases
problem. I don't see the problem with fixed. So I don't see the problem with fixed. My
That's
point
why we
is-
have listed all the parameters here.
Yes, but then you can't give it a minus. I think you should give it an equivalent.
No. I'm not going to give it minus because I'm basing this here on the literature.
Tito, what do you have to lose
Let me just
if you go with telescopic at this stage? It is much easier to maintain later on. The guy has no economic problem, so you can delete this thing. And then let's say that you see that he cooperates and you can add some more implants, do it. But why not go with the easiest way to maintain it if you can achieve it? I agree that it is a little bit more invasive, but if you know how to prepare teeth and you take the control, so I don't see it as a shortcoming.
I don't see it as a problem with fixed.
We have look here.
I have one question. I missed one option. What kind of material are we going to use? And then we can go further in this
If we are
list
going
of
to go
options.
for the material, we're
What
not going
kind
to
of
have.
material? Are we talking about metal? Are we talking about any kind of material what we heard yesterday and today? So what kind of material are you intent to
My
use for
answer,
this patient?
you
Yeah.
don't have a magic solution. You don't have a magic solution. That will work for the whole life.
No, but
We
this
do
is
all
not-
know.
This is not the answer for my question.
Yeah. No, there's no magic material that will work for the best for the whole life of the patient. It's like car,
No.
like everything.
Yeah, but you have a number of options here, and I think you can't give a right answer. Are
Then
we
just
are
wait
we
for the next
saving the
slide.
vertical dimension? Then we can't forget about things like dynamic and things like that. Then we go over to the coin. So this is, I think, a very important option. What is not here in this list? What kind of material are you intend to use?
Well, in terms of
When
material,
it comes up to the prosthesis, 1, 2, 3, the options you gave us.
yeah, for fixed rehabilitation, if you go for single crowns and fixed dental prosthesis, of course, we do know that metal ceramics are the best so far.
Yeah, but I can't see it in the list.
Well, wait, I'm just coming to that
Okay,
point.
great.
Vile, you have to go ahead, otherwise
Yeah.
you're really running out of time.
Yeah. For telescope, of course, you would go for metal acrylics, and this is the whole thing clasp retained as well.
I know that from my German times.
Look now at the long-term data, and this might answer your question. We have here the different types of restorations, different rehabilitations with their outcome, and you can immediately identify that for a clasp-retained removable dental prosthesis, which I call them personally planned extraction devices, because you can see the survival rate after 5 years how it is. So, of course, it's not a preferred option on the long run. we have here the fixed. It is the best one. After 5 and 10 years, we have very good data. And also here for the telescope retained, and this might be because the research is coming from the German-speaking region and it's not populated worldwide, we don't have that much of data, but it shows us also a good outcome, even if we combine it with implants. Please go ahead and scan the QR code, or we have here the reduced URL. Just take a photo, and then you will be able to download all the abstracts with the literature. Of course, because of copyright, I cannot post the PDFs of the presentation or these papers, but I will be happy to provide you one if you send me an email. So, given all these points, we went for modality 4 to combine teeth and implants in a procedure which is telescope-based. Contributing factors, of course, was the patient wish. It is not that removable, that if you compare it, we have very good experience with it. Advantages and advantages of each treatment modality, as well as the scientific evidence. So we went for the following, and I'll be here a little bit quicker. I'm not going to go through. The first thing after the hygiene phase, we do a wax up and a setup diagnostic. And of course, we fabricate provisional crowns and procedures, the interims. And these will be delivered to the patient at the same time with tooth extraction in order to maintain the masticatory function or even to improve it, because we got rid of these very mobile teeth. And now we reassess the situation after 10 weeks. And here we go for a further periodontal charting, as you mentioned, Quilio. And we can see a significant improvement now in the teeth that were also periodontally involved. No bleeding as well on just one spot or 2 spots, but then we were able to continue now and include the implants as well as the teeth. So make the final impression after preparing the teeth, and here it comes the invasiveness that I said about, that you need to prepare the teeth with a telescope retained procedures compared to a clasp retained one. And now you go for the final impression, upper and lower, and then the lab technician will fabricate the inner crowns that they will be verified for their fit, and then we'll go for so-called pickup impression. This pickup impression, of course, is to transfer the position of these crowns in a more accurate manner to the articulator, and then we go for registration of the interjaw relationship, and also we take the height that we have set already with the provisional restorations, we transfer it, we make the bite, and then transfer it into the articulator. The lab technician then will fabricate the secondary crowns and go for the setup. We try in the metal framework inside the oral cavity, and then we definitive tooth arrangement and veneering of the outer crowns takes place. We try it in the oral cavity. When the patient is happy, we try the aesthetics, phonetics, function. Then we can deliver these definitive restorations in the upper and lower jaws, and then afterwards finalize the procedures, as you can see here, that delivered to the patient, with some characterization of the pink acrylic in the upper and lower. And then you can see the situation before and after treatment. Now, that was, of course, less expensive than a fixed rehabilitation involving implants. Is less invasive. It is a good option that has been verified in the literature. And you know what? After 6 years, the patient was in the office last week, and you can see the situation after 6 years of delivery. We have some minor wear of the acrylic teeth, and we have a little bit of inflammation. We have worked with the patient in order to improve the situation, and as you can see here, the situation before and after 6 years of treatment. We're still going well.
Okay, I think it turned out very well. Corey, do you have a comment on this?
No, beautifully done. Beautifully done. Yeah.
It's another option, you know? It's interesting to see other options from...
Thank you. Of course, it's not my work only. I have to thank 2 people that hardly worked on this. Miha, he's also in the audience, one of the very good postgraduate students that I have, best ones, and he is very successful in office. And also the lab technician, Ulrich Ramot, which is a very good one as well in Freiburg, area of Freiburg. Arndt, you want to say something?
Just one comment. I don't think it's the idea of a re-evaluation phase to extract the teeth. You don't know how they react on the treatment.
You are absolutely right. I said the prognosis, and the teeth were hopeless were extracted. And then for the questionable teeth, we went for the reevaluation. I think we can discuss about this the whole day and see which teeth are going to stay or not to stay. But this is the type of treatment that we have provided.
Okay, there is a question from the audience. Yeah, just talk. Go, talk. Don't touch, talk.
Okay. Very nice execution, Weil. But as I saw in the beginning, one wish of the patient was to have a fixed restoration. So what is your comment about that? Because you end up with removable restoration.
Yeah, we discussed with the patient, this is a very good point. We told him if you would like to go for a fixed rehabilitation, we have to put implants. And these would involve 2 to 3 surgeries at least, and then will take duration time because he needed some bone augmentation. Of course, it will take longer than 1 year. In this situation here, we were done within 4 to 5 months after the evaluation, of course, and the whole thing. So the duration of the treatment, given his age, it would have been better to be more conservative rather than going for a fixed approach with involving more invasiveness. But I would agree, if the patient would like to go for implants and insisted on them, I would go for implants.
Okay,
While we don't call it removable, this type of restorations are definitely not removable. They are detachable. And this is much easier for the patients to understand it if you use the correct words, because actually they function as fixed. The only problem might be mental problem to take it out for cleaning, but no doubt that maintaining the remaining teeth in such restoration is much easier for everybody, not only for the patient himself, but also for the dental hygiene.
Agree.
So I don't see any problem with whatever you showed. Plus, you can always add some implants in such, starting from a very stable situation.
Okay, we take one more comment, and then we move to the second case, otherwise we run out. So one comment.
May I?
Yeah, sorry.
Implants in the 3rd quadrant and none in the fourth quadrant, just in the rear.
We didn't do this. The patient came like this with these implants.
He had the implant at the beginning.
Yeah,
okay.
He had these implants.
Let's move.
Yeah.
I mean, the patient is the most important thing.
It's not removable.
If you want to be very provocative in this situation, this case, you just do perio treatment, put the patient in maintenance, that's it, bye-bye. He goes out with a fixed one, that's what he wants, and he has the same situation and he has what he wants. And he would look perfect.
That's why I
only
suggest,
the hopeless teeth.
look, I suggest to all of us, and I do,
it.
I do in my office, I suggest to all of us to have a report from our patients. Send after years, during maintenance, just send a letter at home and ask if the patient was happy with the treatment he received, if he paid enough amount of money, if he paid too much, if he, all the feedbacks that you need. You will learn a lot. You think that the procedure works very well, is very predictable. Actually, the patient hates that procedure, you know? So to have the report from the patient is very important. We need now to move to the second case, which is also address a lot of questions. You will see. Please, move forward.
Yeah. Back to Marcus, just for comment. I just answered Stavros about this, Marcus. And what he got, the patient, again, is we asked him whether he would like to go for surgeries, and he refused it at the evaluation. So it was for us, he chose this option.
Yeah, but to make the last point on this, again, Marcus, there is, as Nielsen said, I mean, there is a big difference between a removable and a detachable. I mean, this is, as a functional standpoint, it's a fix. You can just remove to clean. That's it. There is a big difference. No, come on. It's like this.
He comes fixed. He has a fix in the mouth. And he wishes a fix. He has no money. He has no money.
Well,
I agree.
Marcus,
I agree with everything. But then
he has money. He has money.
he even, when I suggest, he even doesn't need money. He just do.
He doesn't have fixed, he has mobile teeth.
Gentlemen,
He starts with mobile teeth and he ends with something that is fixed. And he's very rich. So let him enjoy
We can
whatever we
discuss-
can do.
We can discuss all the options.
course.
Maintain the teeth and leave
Yeah.
it fixed and do a maintenance program. The patient is happy.
we
You don't
start
need
with
no
that.
implant, you don't need implants.
But they started with that. And at the end, they had to remove the teeth.
Please.
Yeah.
So,
Okay.
please, Vile, go ahead. Go ahead.
This is the beautiful
we
thing
heard,
about it, this discussion.